Check, check. Okay, we're going to go ahead and get started. There's not a lot of people yet, but that's fine. We were supposed to start 7 minutes ago, so we're already late. So, welcome to this afternoon. This is Service Line Development, and our presenter today is Dr. Don Pursley. Some of you have probably already heard him speak a couple of times this weekend. But I will just mention that he has several degrees and lots of experience. And he earned a degree from Chadron State Teachers College and an MS degree in computer science from Georgia Institute of Technology and a doctorate in business administration from George Washington University. He also has served and given finance presentations in many countries, and he served 23 years in the United States Air Force as an aircraft pilot. He was a faculty member and administrator in the United States Air Force Academy. And then in 1990, he became the vice president for finance at Loma Linda University. He spent 14 years at Loma Linda and served as the CFO of LUASC, and he was also an associate professor in the School of Public Health. He is currently an emeritus executive vice president of finance for LUASC, and he's chairman of the board of trustees for Antillean Adventist Hospital in Curacao and Davis Memorial Hospital in Guyana and Trinidad. And one personal note is Dr. Pursley was the board chairman of Malawi and Zambia Adventist hospitals when I went to Malawi. So I was able to work with Dr. Pursley on a turnaround plan for Malamulo and was very appreciative. So please welcome Dr. Pursley.
It's difficult to have a presentation for the speaker and the listeners right after lunch. So we will go together and try to get enough energy to keep alert and make it through. As I mentioned earlier when I was doing strategic planning, the older you get, the more you learn. And you wish you had learned some of the things in your past history so you could apply them. But one of the things I have learned, in many cases the hard way, about hospitals and clinics is we either try to do too much or we try to do too little or we try to do the wrong thing when it comes to services. And so what I'm going to talk to you about a little bit today is maybe a process that you can use in how do you select the right thing for you to do in the right number of things. And I have a question for you. How many times have you heard this? If we could just increase the number of patients, we would be financially okay. And we would accomplish our mission of ministering to people like Christ. Have you ever heard people say that? Just increase the numbers. Yes. All right. I probably said that myself. All volume is good volume. True or false? You know, I have a solution to this. And I told Sanita and I told Beverly that I would give them the CEOs of Curacao and the CEO of Antillean Adventist Hospital and Davis Memorial Hospital the answer on how to increase patients. You want to know how it is? You might try it at your hospital. Okay, there it is. Increase patients? Sure. Sure. Davis Memorial Hospital, free health care, no charges. Would that increase your patient load? Yeah. Absolutely. Absolutely. And for Antillean Adventist Hospital, same thing. Would that increase your patient load? Absolutely. Absolutely. Would you want to do it? What are you going to do then sometimes we want to be all things to all people. Now you look at Loma Linda here. How big a complex do we have here? How many doctors? How many residents? How much imaging? How big is the emergency room? How many surgical suites do we have? How many theaters? Some place like this can be maybe all things to all people. But most of us serve in hospitals that we cannot be all things to all people. It just can't happen. So how do we go about picking what we want to be? Ophthalmology. You want to have an eye center. How about pediatrics? How about a cardiovascular center? In your mind, think about what it takes to do each one of these. The type of doctor you need, the type of equipment you need, the type of facility you need. How about a neurosurgery center? What's that going to take? What popped up? How about orthopedics? Want to do orthopedics? How about just general surgery? How about, for me, geriatrics? Some of us in here, we need the geriatric center. How about radiology? How about an ambulance service? How about a diabetic center? Can we be all of those in the environment that we are operating in? I don't think so. I don't know if there's any hospitals in here, maybe one or two, that can actually do all of that for the environment that you serve in. So how are we going to go about picking what we're going to do? How are you going to be, and how are you going to manage it? That's what we would like to talk about today when we talk about service line management. The answer, selected service lines. Pick the ones that you can do and do well. And don't try to be all things to all people. Now, service line model. It integrates multiple departments, functions, or services that relate to a particular clinical specialty or subspecialty. That's the book definition of what we mean by a service line. The purpose and the focus of a service line, number one, is clinical performance. If you administer a particular service line well, then you should have better clinical performance, okay? Better clinical results of what you do, because you are concentrating more of your efforts and more of your resource on that specific clinical line. Financial performance. You're going to have better financial performance. Let me use an example, not in the healthcare, but of Disney. Disney manufactures a lot of products that they sell. What product makes them the most money? What? Well, that would be, they sell shirts. You think it's shirts? You know what it is? Diapers. Disney makes the most money off of diapers. They make 1 penny, 1 cent, for each diaper that is sold. Now that is kind of amazing to me, but even more amazing to me is the fact that they know that. They manage their product line so detailed and so carefully that they know that they make 1 penny on each diaper sold, and that is the best product line they have. Okay? At the end of the quarter, their financial analysts are updating the information in the computer on the volumes of things sold every 20 minutes. The last day of the quarter. So as soon as the quarter is done, they have their financial report on how their product lines are doing. I'm not suggesting that we are sophisticated enough at any hospital, including Loma Linda, to know to that detail how our service lines or our product lines are being managed. But just to manage, if you could, if you know that you make X number of US dollars on this particular procedure, would you manage differently? You probably would. And if you knew that this particular product line you were losing money, would you manage differently? You probably would. Okay? So it's excellent information to guide you on your finances and accomplishing the mission that you're trying to accomplish. It also gives you patient satisfaction. That is going to come out of clinical performance. You have outstanding clinical performances, and you're probably going to get excellent patient satisfaction. So those are the three rationale, the three focuses of why you would do service lines. What am I doing wrong? Okay. Now, service line success factors. If you're going to go to service lines, here are the success factors that you need to consider. You must select the correct service line. And we're going to get into this in a minute. How do you select the correct service line for your area? You got to have the right organizational structure. You got to have support from senior management. A critical one is you have to have a physician champion. If you don't have a physician that's going to champion this, it's probably not going to work. Okay? So you have to have a physician to take the lead and do it. You got to have staff buy-in, and you got to prevent territorialism, where somebody says, "No, that's my patient. No, this is my patient," and they get to arguing about whose patient it is, and the patient dies. All right. Service line selection. You can select by disease. You can't mix these, okay? So if you're going to go service lines, you can select by disease, or you can select by population. Now, disease may be you're going to do it by cancer, okay, by heart problems, the specific disease, or you can do it by population, okay? You're going to do it by women, men, geriatrics. Okay, you can divide the population, but you can't mix the two. You can't have it by disease and by women. Site or nature of treatment. I'm going to do long-term care. I'm going to do acute care. I'm going to do, where the service is delivered. Or you can do it by procedure or intervention. I'm going to do radiology, okay? So you see, you have to pick one of these categories when you divide up your service lines. If you don't, you're going to end up with, you have selected, developed 3 service lines. Women's health, how's that? That's divided by population, right? Okay. Cancer, how's that picked? By disease. And surgery, that's by procedure. So you have picked 3 of your categories. Now this sounds okay. You picked 3, surgery, cancer, and women's health. What's going to happen? Along comes a woman. She's got breast cancer and needs surgery. Which service line is she in? And if you have a physician champion in each of those 3, you're probably going to have some arguments about, "No, that's my patient. No, that's my patient. No, that's my patient." So you have to pick which service line category you're going to do it by, okay, to avoid territorialism. Now, which ones should you select? The more I have looked at the hospitals that we have, and not necessarily a mission hospital, but the hospitals that are represented in this room, the more I am convinced that the way we need to look at ourselves strategically and position ourselves is that we need to have some primary care areas, such as general surgery, family or general practice, some internal medicine, and some pediatrics. And 1 or 2, maybe 3 service lines. And we don't try to do all of the service lines because we will probably end up doing none of them very well. Okay? So how do we pick then which service line we're going to do? The first thing you have to do is to take your favorite area. What is your favorite area? Or some doctor's favorite area, and make that your service line. Is that right? No, 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 no. You have to go to your population, your catchment area, and find out what are the needs. What are the needs in the population, the catchment area that I have? And you're going to have from example here pretty quick of where somebody has done that very successfully, examining the needs of the population and then establishing a service line to meet those needs. You have to consider, do you have the staff? You might look into a particular area and say, you know, there is a lot of head trauma in my catchment area, and there's no neurosurgery that goes on in my area. So I'm going to establish neurosurgery. You need to stop and think, where am I going to get the neurosurgeon? Where am I going to get the CT and the CT stuff to help this neurosurgeon determine where the problem is? Do I have the ICU to do that? Do I have the trained nurses in order to do the ICU and to do the... So you, even though the catchment area may say you need it, you may not be able to get the staff to do it. You may not get the facilities to do it. You may not be able to get the equipment. Okay, but the first thing is to evaluate the community that you are in and your catchment area and find out what their needs are. I know in many areas that I am in Curacao, in Davis, in Trinidad, they need an awful lot of it. Maybe even in Honduras, they need, there's a lot of diabetics. They need dialysis. They need dialysis center. So, but how do we go about setting up a dialysis center? Okay? It's a niche in your strategic planning that you may pick out a service line and make it exceptional, make it very good. Examples, cardiovascular, diabetics, and cataracts. So I've decided to pick these three. And have I picked by population? Have I picked by procedure? How do I pick? You pick by disease. So I picked by disease. Okay, then the organizational structure is the next thing you need to pick. How are you going to organize yourself to manage these service lines? There are three different models. One is called the pure service line model, one is called the matrix model, and one is called the modified program model. Here is the pure service line model. I do not recommend this one, but it is in the literature, and not very many people use it. And what it basically is that each service line has a director. In most cases, this director is that physician champion. You have to give the physician manager, the physician champion, full decision-making and accountability in order to make this work. The nurses in that service line report directly to this person, as a finance person does, as supply and other people report to that person. And that's the way you manage it. And they report to the CEO. The CFO sits over here doing accounting and central supply. You give to the director of the service line the ability to buy things that they need, supplies, okay? At certain levels, it may have to go to the CFO, and it may have to go to the CEO, and it may have to go to the board. But you give them some responsibility and some accountability, okay? The other model, then, is what is called a modified service line. You notice on that other one, we did not have a chief nursing officer. So who is going to establish nursing standards across the hospital? This one recognizes that and says, well, we need the CNO to sit here and establish nursing standards across the hospital. Now, what happens here, and in the next one, is nursing has two bosses. Some people cannot handle that. They have to respond to the CNO for different protocols and standards, and they have to respond to the service line director in operational matters. Okay? Then the next one is what is called the matrix model. And this one you have everybody answering to two bosses. Now it takes a unique individual to be able to juggle what two bosses are telling them to do. Okay? It can be done, but it takes a unique individual. You have the CNO, The diabetes service line director supervises nursing, supervises purchasing, supervises pharmacy, supervises all the way up, and they also go up to the CNO, the CFO. So these people have two bosses. Now, the literature supports this one here. They say most of the successful service lines have this modified pure service line model, where you have somebody sitting out here, the CNO, establishing standards. You could have the CFO sitting out here establishing guidelines and monitoring the finance people. You could have the head of supply, and these people will end up with two supervisors, but this one appears to be the one that is most consistent out there in the literature. All right. You must get the support of senior management. You may, as the CEO, have this as your vision, and you want to start down this line, but if your CNO, your CFO, and your CMO do not support it, you're going to have problems. Why would not the CFO support it? They're going to lose a little authority, aren't they? How about your CNO? They're going to lose a little bit of authority. How about the chief medical officer? They're going to lose a little bit of authority because the champion physician may not be the CMO. And you've got to give the champion physician some authority to actually facilitate change and get that service line going, along with the accountability. Absolutely critical. Now, I don't know who this is, support of a physician champion, but you got to have the support of the physician champion, or it just is not going to work. It's not going to work. Staff buy-in. Everybody that's out there that does this, that supports the service line, needs to know who they're taking orders from. And it may be two people. They need to know they need to cope with that. They need to work with that. This prevents territorialism. The best way to prevent that is the way you select your service lines. Remember we talked about those 4 ways? If you intermix those, you're going to have a territory problem. People are going to no, that's my area, no, that's my area. And again, they get to argue, and I've seen that. They get to arguing, and the poor patient is off there someplace waiting to be treated. And the cancer people are saying, no, 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 that's mine. And the surgery people saying, no, 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 that's mine. And the oncologist, no, 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 that's mine. And the poor patient suffers for that. So, how to distribute the income. We're going to go through this quite rapidly because I want to have you go through a case study at the end. We may not be as sophisticated as we need to be in our accounting software in order to distribute the income. If you have expenses, the direct expenses in a particular service line, you can just directly put it in as expenses in that service line. But what about finance, maintenance, housekeeping, personnel, security, depreciation, utilities, insurance, and there's other? How do you distribute those? And the most acceptable way, for example, finance is the size of the budget. In other words, if you have a budget and the service line uses 1/10 of it, then 1/10 of the finance budget is applied to that service line. How about maintenance? Do it by space. Housekeeping by space. Personnel, employees. Security by space and employees, because they both create security needs. And depreciation, space and equipment, and so on. So you distribute, not an exact science, but you distribute your expenses in these indirect areas into those service lines, so you financially know how that service line is doing. Okay? Okay. Summary. The success factors. Select the correct service lines. Select the correct organizational structure. Support of senior management, staff buy-in, and prevent territorialism. And the one I left out is, to me, the most important: support from a physician champion. At this time, I would like to introduce Dr. Christy Shank, who I think you have heard before in some of the presentation, talk about a case study of Malamuta Hospital. So, Dr. Shank.
Thank you, Dr. Pursley. We'll switch over now and just talk about the Women's Center that we talked about briefly before. How do you go about establishing something like this? This was a hit or miss trial for Malamulo, and I'm pleased that Dr. Pursley thinks that this was worth talking about. So let me just do a very brief walkthrough of how we actually came to the decision to do a Women's Center and what was involved in that. For those of you who are not familiar, this is Malamulo Hospital. It's about a 175-bed hospital in rural southern Malawi. For those of you who aren't entirely sure where Malawi is, you're not from our divisions, Malawi is highlighted there on the screen just underneath Lake Victoria. Very small country, about 16 million people, many of them concentrated in the southern part of the country. Malawi's health structure continues to struggle, unfortunately. And one of the areas that it, I think, has the most difficulty addressing is in public health. As governments develop, they deal first with the acute care issues and then move on to adding in public health. And Malawi's in the process of doing a good transition to doing more public health and more community work. And so these ladies are a population that actually don't get addressed as well as we would like for them to be. So especially women in rural areas have a very difficult time accessing care. And this is true all over the country, not just in the southern region. And it's for a variety of reasons. It's for transportation reasons. People often have multiple children. How do you leave those children at home when you're trying to come to the hospital? Is it physically safe for you to walk to the hospital? And how many kilometers away is that? And then how do you find the funds to take out of the small amount that your money has to be able to access care? So these are really the issues that our women run into. They're so busy, as was mentioned by Dr. Pennycook this morning, they're so busy taking care of other people that mothers and women often forget to take care of themselves. So this was something that we, as we talked with the community, felt more and more strongly about, that this was an area and a potential that needed to be tapped. This was not a formal discussion. We have the chiefs of our traditional villages who sit on an advisory board for the hospital, and this is not something that they mentioned in specific, but just a general concern about the health of women and what are we going to be able to do about that. So this was mentioned by our local traditional authorities. It's also been known as a problem within the Malawi strategic plan for the Ministry of Health, and so they've identified this as a problem as well. So that was where the initial idea came from. And it also came from our clinical staff at the hospital as well. Seeing women come in with advanced cervical cancer, we know that this isn't necessary. We know it's preventable by screening and treating early. And so it was also a concern from our local staff members at the hospital as well. So these were the population that we were really trying to reach. I think I mentioned in our earlier discussion, there had been a policy change in Malawi government policy, which often changes what you do at the hospital. And so that policy was that we were no longer admitting tuberculosis patients into the hospital as a routine, just if they were sick enough to need to be admitted. And so we had a 50-bed facility, the floor plan of which you see, and that was for a tuberculosis ward. So this used to be that there were about 10 beds in each of these open bays, a 50-bed facility where people could stay for 2 weeks to 2 months to start their TB treatment. And unfortunately, it was no longer needed. So that space became empty about a year ago, in December of last year. And so the hospital, as an administrative committee, took a look at that and thought, what can we actually do with this space? We don't want it to go to waste. We want it to make a significant impact in our community. We already had multiple community programs going, childhood vaccination, nutrition checks, antenatal services, and all of those are crammed into a very small building. And so we thought we really can't add any new services into this building. We need a new physical structure. And so a lot of what came into this was that we looked at our physical space that we had and said, if we're going to renovate this into a women's center, what would that look like? And so I'll just show you a few quick pictures of us in the process. This is the bathrooms that were there in the very beginning, obviously in dire condition and needing rehabilitation. The ceilings had been painted 30 years ago and really hadn't been addressed since then, so there's paint peeling off the ceilings. Not a very attractive place that you would want to go for your medical care. So this was all something that we started to do with our local maintenance staff from the hospital. The gentleman that you see there is Mr. Jumbe. He is a a contractor who we've now hired at the hospital. And so he was responsible for putting in dividers into these big open rooms so that they could have a private space for examinations. And he did a wonderful job. Our plumber putting in sinks. Somehow within this particular ward of the hospital, there had been no running water installed when it was constructed 30, 40 years ago. And I think looking at upgrading your facility, what does it actually take to run a program? Obviously, you need to be able to wash your hands. This is a key part. And we found actually that our hospital maintenance crew loved this project. It's for women, it's not for them. They loved this project. And I think the reason was because they saw how their job, which is not often very recognized, turned an unused space in the hospital into something that really functioned well and the community is really appreciating. And so these gentlemen who have very minimal education have really realized that they can make a significant difference in their community as well. And I was amazed at what they could do. They tore out, you can see this is at the base of a giant tree that's been there for about 40 years. The tree grew, the bricks cracked, the wall fell over in the waiting area out in the garden. And so these gentlemen went out there, dug everything up, sorted it out, put in a new brick wall, sorted out the bricks on the bottom. And this was just their own initiative in talking with each other how they could fix this. So it was actually quite a team building experience for our maintenance department as well. They figured out how to make benches. This is the education area. We thought that promoting women's health in terms of their sexual health and in terms of their need for screening programs was a very important part. And that in Malawi requires lots of group education. And so that means they need a space to sit together. You don't educate one-on-one, you educate in a group, because people feel more comfortable that way. And so it's important to have a friend sitting next to you and someone else who asks a question that you're sort of afraid to ask, and it works much better in that way. And so this is actually the education room where people can sit together and receive their education and training together prior to the examination. And this is just a shot of the newly finished on the interior side. There's a beautiful inner courtyard of this area. You can see the garden is still growing. It's been newly planted. And then you can see the brick archways that go all the way around. And so the examination rooms are located all the way around. And so people were very proud. Our hospital staff was proud. Our maintenance team was especially proud of the way that this had turned out. So this is the response. We had one of our women go out. The nurse whose back is to you, Mrs. Panulo, has been responsible for going out and educating our communities about what was going to go on. And so she did an excellent job, she and her team of about 5 other people, including health surveillance assistants who have no training except that they've been assigned by the government to promote health within their communities. And so she and her team of HSAs went out and organized all the communities. They said, right, women from this village, you're coming on this day. Women from this village, you're coming on this day. And they just went right down the line and scheduled it out. So we had a team who came over from this area and taught both physicians and nurses their different respective roles. So here you see Dr. Dominique Shaw, who's seated at the bed at the end of the patient, and standing beside her is Dr. Martha Maquero, one of the local physicians from our sister hospital, Blantyre Adventist, who was trained in doing colposcopies and LEAPs, the procedure to remove early stage cervical cancer. So the advantage of this system is that we can actually have women come in, they get their examination and their pap smear done, and then if they fall into, we find that they have an early problem, those women come back when they receive the results of their pap smear. That very same day, we say, excellent, you are referred over to this room. We're going to do your treatment and your surgery now immediately so that this problem is taken care of. And obviously that requires laboratory support to be able to do that. And so this is a photo of the lab that has been designated within the Women's Center. We were very fortunate that Loma Linda has assisted us. Both Malamilo Hospital and Blantyre Adventist Hospital both had a cytotechnologist who was trained here at Loma Linda via a short course program. So they are now able to read those pap smears, and we'll be doing that together, assisting so that we're able to provide immediate feedback to the women and we can provide the prop treatment at that time. So this is just a quick idea of what can happen if you work together with your staff. So we went into this in a very uninitiated fashion. We just basically looked around and thought, what would actually help our community? Now, having come through it and reading a bit more about how do you intentionally select, these are the things that we went through in our process. So as you're trying to choose your service, go out in the community, look around what's happening in your community. If you don't go look, you're never going to know. So I think that's the key point. One thing that helped me quite a lot was to read local country reports and then also international reports. For example, from the WHO, who provides guidelines about what things should be going on within your area. And if you read those international reports, you think, oh, we're doing a bit of this, we could do better on that, oh, we're not doing this at all. And that was certainly where this women's health care came in. Look at national goals. Certainly within Malawi's national strategic plan, cervical cancer is one of the areas that they want to focus on. And they were delighted to have us partner with them. We met several times with the Ministry of Health officials for this particular area, and they were very glad at what was going on. So be sure that you link and partner in, that you're trying to accomplish the country's strategic goals as well. That makes it much more well recognized and accepted. Involve your traditional leaders, your chiefs, or whoever the traditional authority, if traditional authority is important in your community, you need to link in with those people as well. We're fortunate that the chiefs around our hospital love to be involved, and they sit on our hospital advisory board, which meets every quarter. And they give us invaluable feedback about what the community is concerned about, what things they think are going well, recommendations for the hospital, and that feedback has been really important. And then remember, don't just ask the chiefs, ask the common person, the person who comes in and cleans your yard or helps you in the house. Ask those people. They know what they need in their community, so don't forget to ask the common people that you run into every single day. So that's sort of what helped us choose our service. On the right side, you'll see some questions, and these are more intrinsic to the facility, not the community. What are you as a facility interested in? It does us no good to choose cataract surgery, for example, which would be excellent, but no one in our community nor in the hospital itself are really interested in that at this time. So don't choose a project that no one's really excited about. It will never fly. What's currently being funded? Is there interest in your area right now? We have excellent guidance by the Millennium Development Goals, and maternal child health has taken a huge forefront within that. So anything that you do that involves the Millennium Development Goals, and in particular maternal child at this point, is more likely to be funded, and you're more likely to find outside help for that. How much will your service cost, both in terms of personnel, in training, in materials? Those are all very important. Don't forget that just because you start a new service, it doesn't mean that you can keep going. So we're using an existing facility. We used our existing staff to do the renovation, and we're also using our existing staff to run the new service. Eventually, we're going to need to train more people to do that. So think of what you can actually support at the beginning, and then what's the development ability that you can do with your program. And then finally, who can help you? We've been very fortunate that we linked up with PAPS Team International, who came over and did our training for us. They donated invaluable equipment, the cryotherapy equipment, the LEAP equipment, multiple microscopes. Those are things that we as a struggling mission hospital would not have been able to initially fund. And so to find people who are interested in the same thing that you're interested in is really key. You need partners to help you. And those can be international, they can be local, they can be within your government. It really doesn't matter. You just have to look around for who's interested in what you're interested in. So that's a quick run through of how we ended up developing our process at Malamulo. We're interested to see how it will continue. It's only been going for about 2 months now. So hopefully we'll be able to continue on and give good feedback at some point.
Great. Did you pick out? Yeah. Did you pick out the need, what you need to make it successful? Was there a physician champion? Right there. Okay. Was there employee, staff buy-in? How about those maintenance guys out there? They bought into that. Very critical. Was there the meeting of a community need? Absolutely. Was the facilities able to cope with it? Absolutely. So if you go down through those lists that the literature says you need, Malamulu, under Dr. Shank's leadership, really accomplished every one of those. It is a proven scientifically, I think, that who controls the health care of a family? The woman. The woman. So, if you want to build your census, if you get women's health, which, it takes some work to do, but if you get women's health, do you pick up then the pediatrics? And pretty quick you're going to pick up the spouse. Okay? So women's health is probably something in all of your areas that you may want to look at. This was particularly important because I think of ovarian cancer was one of the big things in Malawi that was not being cared for.
Cervical cancer.
So with that, you haven't held up the 10 yet, though. Oh, there's the 10. Okay. Questions that you might have for Dr. Shank?
I have a question. I also have the microphone. Another question. Ready? I'm curious about, maybe you can talk a little bit.
It's going.
Maybe you can talk a little bit about the cost of starting up this service line. How did you fund it? How did you fund the renovations? And then what are you charging for this service? And what do you see as is there profit? Have you done any profit analysis or income-based analysis?
It's basically a project because of ethical reasons and an interest within the community. So the finances, I think, are the stickiest part of it. The money that was used to do the physical renovations and the initial training, PAP's team volunteered their time. The initial renovations were actually all church donations from churches that I have spoken with and other people have spoken with here in the United States. And so there had been a donation initially of about $6,000 US that had been sort of saved because we didn't want it to just put it in the general operating cost and it get lost. And so that money had been saved aside to do a particular project with. And the timing of the government's decision, along with the timing that we got connected with PAPS International and realized that we had a space and people who would come out and do training, we thought, let's use that money to fund this initial project. There will be an ongoing fee for services, but we don't want it to actually limit women coming in. So we're going to be charging less than $1 a day for women to come in and actually get their pap smear done. This will obviously not fund the ongoing project. So we're going to have to look for outside funding. One is that women within Malawi, even upper middle class women, don't actually have a consistent place where they can come that is designated for women for cervical cancer. And so we're hoping to be able to draw in the middle and higher class women to help subsidize what we're doing for our own community.
Any other questions?
Please make her run up the steps. No. That's good. Thank you.
Thank you very much.
That was good, Chrissy. That was
Please
well
remember to fill out your green evaluation forms. And you can write in Dr. Shank's name. She's not listed there, I don't believe. But feel free to add an evaluation as well. Dr. Hart, are there any announcements? Okay. I believe the next thing is the final wrap-up. And that'll be in the DeMazo, the next door amphitheater. And that'll be sort of our wrap-up session before the evening festivities.